So a huge thanks goes to Charlie, to Tom, and also to all of you that you're staying here. So conflict of interest, I actually do have one conflict of interest, and I am a big fan of weight-bearing CT. I will show you some of the studies I used weight-bearing CT. However, there is no financial profit. So, and Charlie gave me like a topic, something about hindfoot and midfoot. And when you take a look on those pictures, everything here is hindfoot and midfoot. So maybe not the ends of metatarsals, but otherwise a lot. So, and I was thinking, how about the subtalar joint? And this is a typical answer from Charlie. Excellent, my favorite joint. So, and then I decided this topic. So subtalar joint anatomy is quite complex. I agree. If you ask elbow surgeon will say this is complex anatomy. If you would ask knee surgeon will say it and have complex anatomy. But when you compare subtalar to the tibiotalar joint, then I hope you would agree that the subtalar joint is more complex. So there is several surfaces articulating, for example, posterior, intermedial anterior, and talonavicular. Then this joint has also two major stabilizer. This is CFL, a calcaneofibular ligament, and this is interosseous ligament. And there is still a debate which ligament is more important for stabilization. And we will discuss about this just a little bit later. We know that the congruency of this joint is less than for the ankle joint. So it is not as congruent as possible, and there is more variability between the person, as we were able to show using the shape modeling. So I have to tell you that subtalar joint has been neglected for a long period of time, and this is like a Cinderella. Subtalar joint is Cinderella, and ankle joint are those bad stepsisters. Take a look on the PubMed, for example, when we're looking for the literature. If you type in ankle joint, you will find almost 35,000 results. When you look for subtalar joint, there's about a 10th of this, but God bless, you can see that the interest is still increasing. How about osteoarthritis? Let's not first speak about ankle osteoarthritis. We know that about 6% of adult population have ankle osteoarthritis, more or less. And there are enough epidemiological studies addressing ankle joint osteoarthritis, including this work from Charlie Saltzman. What about the subtalar joint? There is actually so far no evidence-based literature. I'm working in Hamburg, but I still spend every Sunday between 4 and 6 hours Zooming with Utah because I still have a research group there, and one of the residents is preparing systematic literature review on subtalar arthrodesis. And so far, he included 100 studies with almost 4,500 feet. And he was able to find out that the most common etiology is post-traumatic, also similar to the ankle joint. How does it happen? It happens mostly when the patient have quite bad calcaneus fractures. You can see here, for me, it doesn't look like a calcaneus. This is something quite difficult to fix, especially if you are planning to do a good job. And this is actually a very interesting paper from Dave Rodberg and Brett Yu. Dave Rodberg is an associate professor working in traumatology at the University of Utah. They did a prospective study, and they took a look on cartilage in every patient, they fixed the fracture. And they figured out that in up to 100%, depending on fracture type, they were able to find some cartilage damage. So this explains why post-traumatic etiology is still very important for this joint. So subtalar instability, I'm pretty sure maybe some of you had already ankle instability. Maybe even some of you had the surgery for ankle instability. I am 100% sure that Ned Amendola, Professor Amendola, did 1,000 ankle stabilization procedures, maybe even more. But how about subtalar joint instability? This is one of my last talk for Park Foundation, and there is still a question: does the subtalar instability exist at all? So the enigma of subtalar instability. No one would think about the topic enigma of ankle osteoarthritis or ankle instability. So the problem is the subtalar instability is quite difficult to diagnose because those two joints are very closely, and there are also some ligaments which stabilizing both joints. Tibiotalar means ankle and subtalar joint. And this is a systematic literature review which has been performed by Nicola Kreinbill, who is now head of foot and ankle department at the University of Basel, where I worked a couple of years ago. He came for 1 year to Utah for research fellowship, and he went through 23 imaging studies, and those are like typical measurements, and mostly conventional radiograph were used to measure the instability. Unfortunately, the conclusion was that there is no reliable measurements of subtalar instability. So we would be happy to give some advice, but we were not able. So should we just give up? Of course, no. We used weight-bearing CT. Weight-bearing CT is a quite new technology. It's actually not like a normal CT scan. It's a cone beam CT scan. So it's about 1/7 of the normal radiation when you do foot and ankle CT scan. Then we created radiolucent frame so we could apply the weight, and we could also apply the torque. And first, we analyze 2D data to the 2-dimensional, but I don't wanna talk the entire day about this. Very interesting to see the 3D analysis. This has been performed mostly by Arne Bursens, who just defended his PhD at the University of Kent. Also, he spent almost a year at the University of Utah, and he compared native unloaded subtalar joint versus full sectioning. That means that the stabilizing structures were just cut surgically and loaded with weight, with body weight, because then when you get the specimen, you can figure out what was the weight of the person who donated his body or her body. Then we analyzed how about the internal torque and external torque. So this is the first picture. Green means is completely intact, and orange means there are some instability. So there are changes. And here you can see the green is definitely dominant side. When you apply internal torque, and 10 Newton meters is not that much. For example, when you stand on one leg and you turn your body around, this is already more than 10 Newton meters. And here you can see there is already more orange color, and it changed quite dramatically when you do the external torque, you can see there is almost the entire joint shows that there is orange. That means, in our opinion, this is the best way to diagnose subtalar instability. And right now here in Hamburg, we also have a weight-bearing CT, and we are performing a prospective study on the patients with ankle and subtalar instability. Let's talk about end-stage subtalar OA. This is a quite typical course. This guy has been fixed by our colleagues from traumatology. I don't think I could do a better job. First, I removed the hardware and he was happy for 2 years, but then he came back and then I fused it. And the question is how the patients are doing after the subtalar joint is fused. Here, I would like to present the data we won already from this systematic literature review, which hasn't been published yet, but it will be published soon. Very important visual analog scale. That means pain. And you can see that fusion of the subtalar joint can reduce pain by half. There is almost no patients who have zero pain. This is important to talk to patient, to consent the patient. However, the patients are quite satisfied. Why the patients don't have zero pain if you do a proper job? The problem is they had already several surgeries, so the soft tissue envelope is quite damaged, and this may explain why they still have the problem. Another important outcome is the healing. So when we fuse two joints, we remove the remaining cartilage and we try to put two joints together, as we heard today during this webinar. And actually, the healing rate is quite comparable to the ankle joint. This is a very nice clinical study performed at the University of Utah. So the healing rate is about the same. Very interesting, and this is the last part of my talk, is the rule of subtalar joint in hindfoot motion. And this study has been performed using dual fluoroscopy. So the patient first gets CT scan, then the patient walk between two fluoroscopies, and this 3D model from CT scan will be transferred to the imaging which you get from fluoroscopy. It's extremely time-consuming process, so it is you can't include like more than 10 patients because there is no enough undergraduates you can hire for this job. For me, it was very surprising that subtalar joint is contributing a lot to plantar flexion and dorsiflexion, because what I learned, dorsiflexion, plantar flexion comes from the ankle joint, and those movement comes from the subtalar joint. This is actually not true. There is, like, for example, when you go to the toe off, this is almost the same amount of dorsiflexion, plantar flexion comes from the subtalar joint. And what happens with the subtalar joint when you fuse it? This is a paper we published recently in JBJS American. Those are patients without the pain who had ankle fusion. And you can see what I explained before, how it looks like. And very interestingly to see that you don't have to go in details, but you can clearly see that when you go over ground walking, there is more subtalar plantar flexion, which means motion. And this gets even more dramatically when you do subtalar plantar flexion. So some of you may say 7 degrees, this is almost nothing, but keep in mind how many millions of the steps the patient still have to do. So this explains why the patient may become secondary osteoarthritis in the adjacent joints when you do the ankle fusion. And this is pilot study. So we did this also with ankle replacement, and gray is the normal, and the black line is actually this one ankle replacement using Zimmer, and it's not perfectly to the gray line, but very similar. And in the meantime, we did it in 6 patients, and we submitted these results to Foot and Ankle International. So to conclude the talk, we can say subtalar joint has a complex anatomy and biomechanics. There is a different entities of subtalar joint pathology. For example, subtalar instability, which definitely needs further research. Then subtalar osteoarthritis, and here plays the injury very important role. And I just wanna speak very briefly about these 2 papers, which has been done by Justin Haller, another traumatologist here at the University of Utah. So when you have intra-articular fracture, that means fracture goes through the joint, there is a lot of inflammation within the joint. And we don't know, is it good or is it bad? We know that the healing goes through inflammation, but maybe is it just too much inflammation? So maybe we can block some of this response to avoid later the osteoarthritis. And up to date, the fusion is the only one existing surgical option, so there is no way to replace it. And keep also in mind, subtalar joint is a Cinderella. So when you fuse your ankle joint, it does the work for the tibiotalar joint regarding walking, running, etc. So I'm pretty much, at the end, I can say pretty much humbled to be part of this webinar, because when I see Ned, when I see Judy, when I see Tom, those are the guys where I read the paper as I was residents. Those were my mentors, although at that time I never met them. I don't want to say they are much older than me, but I know I'm not at their level, and I am really, really happy to be here. So therefore, again, big thanks to Arthritic Foundation, great thanks to Charles Saltzman for inviting me, and also very, very big thank to Dr. Clanton, to Tom, who really took his time for a phone call to discuss about this talk. So thank you very much for your attention.